Okay.
Is this?
I can't, it's not on here. So, oh, maybe it is on here. There we are. Let me just get my laptop out of the way here. So, question 1. Angio-CT is a non-invasive way to diagnose ocular ischemic syndrome. 2. Fluorescein angiography is optimized to image the choroidal vasculature. 3. ICG is the definitive... Oh, you want that back? Yeah. Is the definitive test for identifying polypoidal lesions. 4. Angio-CT is a good substitute for fluorescein angiography at identifying microaneurysms.
You can start voting now. Okay, stop. Can we have the results, please? Right. There is clear preference. Yeah, come.
Right. So the first one. So angio-CT is not a dynamic test, and to diagnose ocular ischemic syndrome, you need to see that the filling into the eye is slow. Angio-CT just does a static time shot of just seeing movement in the blood vessels. So you can have a normal angio-CT and have ocular ischemic syndrome. You need a dynamic test to do that. Everyone got the fluorescein angiography question 2 correct. And ICG is the definitive test for diagnosing polypoidal based on the Everest criteria, although OCT may give you hints that you may need to do an ICG. So the OCT may be a useful screening tool, but not been fully validated against ICG. And angio-CT is not a good substitute for identifying microaneurysms, because the flow in microaneurysms or polyps is very sluggish, and because of artifact problems in angio-CT, they've had to have a lower limit of cutoff, the designers of the machines, to not detect low flow, otherwise there'll be too much noise in the image. So microaneurysms have low flow, and many of them you will not pick up compared to fluorescein on the images.
Yeah.
Okay.
So we proceed with the second question. How many do you have?
Just 2.
Okay, quick. That's fine. Brilliant.
Yep.
Okay, let's put them up. Second question, please. Right.
Okay, so question 1, geographic atrophy is effectively treated with anti-VEGF. 2, continuous regular anti-VEGF is associated with best average visual acuity outcomes in eyes with neovascular AMD. 3, the AREDS formulation reduces the risk of neovascular AMD occurring in eyes with wet AMD in one eye. And 4, AREDS 1 formulation is safe in recent ex-smokers.
You can start voting now. Okay, let's see the results.
Yep.
Okay, that's
I
really
assume
good.
everyone would get the first one. I'd be worried if they didn't. Although I have had patients who've had that treatment. So continuous is the best average. So I showed one paper. So there are caveats to this, so I can understand why there was a slight difference. I showed slides on the T-REX study, which was only 1 year follow-up of continuous versus treat and extend, with relatively small n showing no major difference. By and large, we assume over a longer period of time, the average patient would do better with continuous than treat and extend, but I can understand why 20% of people thought otherwise. AREDS formulation, so does reduce the risk. And the last one was AREDS 1 and ex-smokers. AREDS 1 contains beta-carotene that increases the risk of lung cancer in smokers or ex-smokers. You need to use the AREDS 2 formulation.